Thank you for listening to this presentation. My name is Emily Moore and I am a student physical therapist assistant. I am reviewing an article found in the American Physical Therapy Association Journal. The article is titled Effectiveness of the Canalith Repositioning Procedure in the Treatment of Benign Proximal Positional Vertigo. The article examines evidence to determine the effectiveness of the canalithic repositioning procedure. Benign proximal positional vertigo is a mechanical disorder of the inner ear and is caused by abnormal stimulation of one or more of the three semicircular canals. BPPV occurs as a result of otoconia, which are tiny crystals of calcium carbonate that are a normal part of the inner ear's anatomy, detaching from the membrane in the utricle and collecting in one of the semicircular canals. When the head is still, gravity causes the otoconia to clump and settle. A person suffering from this disorder may experience dizziness, a spinning sensation, lightheadedness, unsteadiness, loss of balance, or nausea. The inner ear has three semicircular canals: the horizontal, the superior, and the posterior semicircular canal. This illustration depicts left posterior semicircular canal, BPPV. As you can see, the crystals are clumped together in the posterior semicircular canal. This posterior semicircular canal is the most commonly involved canal out of the three. There are two ways to test for BPPV. The Dix-Hallpike test and the sideline test are the standard tests for evaluating posterior canal BPPV. The Dix-Hallpike test is performed with the patient sitting with legs extended on treatment table, and the patient turns their head 45 degrees towards the direction of the ear being tested. The patient is instructed to quickly lie back onto the table with assistance from the clinician so that their neck is extended 30 degrees. The clinician observes the patient's eyes for about 1 minute. The sideline test is very similar to the Dix-Hallpike test. The patient begins seated at the side of the examination table. The patient's head is turned 45 degrees away from the side being tested to align the posterior semicircular canals with the plane of movement. The patient is quickly laid onto the side being tested, and again the clinician observes the patient's eyes for about 1 minute. A positive result for both of these tests would be torsional or rotational nystagmus or an upbeating nystagmus. In both tests, the nystagmus should begin after a brief latency of 5 to 10 seconds. Now, this research article looked at the effectiveness of the canalith repositioning procedure, which is used to treat BPPV. The clinician moves the patient through a series of 4 positions, starting with the placement of the involved canal in the head hanging position of the Dix-Hallpike test. To begin, the patient is positioned on the treatment table in the sitting position with legs extended. The patient's head is rotated 45 degrees, and the patient is then lowered into a supine position with the neck extended 30 degrees over the edge of the treatment table. This is the head hanging position. The head is rotated through 90 degrees of motion, ending in 45 degrees of neck rotation towards the uninvolved side. This step is followed by rolling onto the uninvolved side while maintaining the position of the head in relation to the trunk, and finally sitting up from lying on the uninvolved side. Each position is maintained for a minimum of 45 seconds, or as long as the nystagmus lasts, plus an additional 20 seconds. The procedure is repeated a minimum of 3 times. The journal article looked at 5 small-scale randomized controlled trials that looked at the effectiveness of the canalith repositioning procedure to treat BPPV. Together, the studies had a total of 292 participants, all over the age of 16. All the participants were clinically diagnosed with posterior canal BPPV using the Dix-Hallpike test. The canalith repositioning procedure was compared with a sham maneuver for 4 of the trials and compared to a control group in 1 trial. Each study did a follow-up assessment either immediately after treatment or up to 1 month later. This table shows the outcomes of each of the 5 studies. Looking at the results here, you can see that there was a significant improvement in symptoms after treatment. In the first study, 50% of the participants had a complete resolution of symptoms, and 67% had a negative Dix-Hallpike test after treatment. In the second study, 61% had a complete resolution of symptoms, and 89% had a negative Dix-Hallpike test. In the third study, 32 participants had a complete resolution of symptoms, and 34% had a negative Dix-Hallpike test. In the fourth study, 80% had both complete resolution of symptoms and a negative Dix-Hallpike test. In the fifth study, 41% had complete resolution of symptoms, and 76% had a negative Dix-Hallpike test result after treatment. To reiterate, there was a significant improvement in symptoms after treatment using the canalith repositioning treatment. The symptom resolution had an odds ratio of 4.42. There was also a significant difference in conversion from a positive to a negative Dix-Hallpike test with an odds ratio of 6.4. As clinicians, we will be treating patients who are dealing with vertigo. During my clinical rotation, the physical therapist I worked with had several patients dealing with BPPV, and he used the canalith repositioning procedure to treat those patients. The article did have some limitations. All of the studies that were examined had small sample sizes of less than 100 participants. The outcome of the treatment was not assessed more than 1 month after treatment, and so there is no evidence of long-term symptom resolution. The article also did not address age range, race, or gender of any of the participants in the studies. Here are the references I used for this presentation. Again, you can find the journal article in the American Physical Therapy Association Journal. Thank you for listening to this presentation.